Every year in the United States, more than 200,000 men are diagnosed with prostate cancer. Here at the Hollings Cancer Center, an NCI-designated center, we take a multidisciplinary approach to managing your prostate cancer. When you come to Hollings, your case is going to be reviewed by a urologist, a radiation and oncologist like myself, and a medical oncologist, along with specialists in radiology and pathology that focus on prostate cancer. Prostate cancer is divided into 3 risk groups: low, intermediate, and high. We use these groups to help determine how to best treat your cancer. Please remember that the video we're providing today is only a brief introduction to how to have your prostate cancer managed and the options. And the reason we're providing you with this information today is so that when you do come in to speak with your urologist or your radiation oncologist, that you'll be better informed and you'll have a better idea of how your prostate cancer should be managed. High-risk prostate cancer is a problem that definitely needs aggressive treatment for most men. The definition of high-risk prostate cancer, as far as I'm concerned, is patients with a Gleason score of 8 or higher, a PSA greater than 20, or evidence of the cancer spreading outside the prostate on a physical exam. So gentlemen who have any of these features, we consider to have high-risk prostate cancer, and they need to consider which aggressive treatment they want to pursue. If left untreated, this type of prostate cancer, unlike the other slower growing types of prostate cancer, can cause life-threatening problems in the next 5 years. So they definitely need attention and appropriate treatment. Standard treatment options for patients with high-risk prostate cancer include radical prostatectomy, followed by close observation, or radiation combined with hormonal therapy together. Radiation therapy is typically not given without hormonal therapy if you have high-risk disease. It's been shown that we really need to combine the 2 treatment modalities if we want to give you the best chance of getting rid of the prostate cancer completely. Surgery can be done for these high-risk patients, and there is a chance that you won't need any further treatment. However, patients need to understand that most patients with high-risk disease who have surgery will need radiation and hormonal therapy sometime after their surgery. So most gentlemen elect to avoid surgery and move forward with radiation and hormonal therapy. Now, radiation therapy in this setting can be done one of 2 ways. The first way is the least invasive. It's once a day, Monday through Friday, external beam radiation. It's given about 5 to 10 minutes treatment every day, Monday through Friday, but it's every day for approximately 2 months. So it is an extended treatment time compared to surgery. The other way to have radiation therapy is combining external beam with a seed implant. A seed implant is also called low dose rate brachytherapy. It's an outpatient procedure where we put small radioactive pellets in and around the prostate in an effort to deliver a very strong dose of radiation right to the area where the cancer is and minimize the dose of radiation outside the prostate. If we do a seed implant, we also need to combine it with about 5 weeks of the external beam radiation therapy. So it's the combination that really works best for high-risk patients. In addition to these 2 forms of radiotherapy, we also recommend hormonal therapy with either radiation approach. In this setting, hormonal therapy is given for a few months before treatment, during treatment, and for 2 to 3 years after radiation is done. So one of the big differences between surgery and radiation in this setting is that if you do radiation, we do recommend that you have hormonal therapy, which causes low testosterone, for at least 2 to 3 years after and during your treatment. The reason we use hormonal therapy is that multiple studies have shown that we actually improve the chances of getting rid of the cancer completely and you actually being alive 10 years after treatment with the hormonal therapy and radiation compared to radiation therapy alone. No study has shown that there's a significant benefit to adding hormonal therapy with surgery, so we don't use hormonal therapy with surgery even for high-risk patients in a typical setting. External beam radiation therapy, seed implant, a form of radiation therapy, or surgery, they all have potential toxicities and side effects. So I'm going to go over those now. One of the differences between intermediate risk and high-risk prostate cancers is the duration of hormonal therapy that is needed to treat the cancer if you're selecting radiation therapy as your treatment modality. So if you don't have surgery and you go with radiation, hormonal therapy has been shown to improve outcomes in patients with high-risk prostate cancer. It does come at a price. There are side effects from taking hormonal therapy for 2 to 3 years. Most patients have hot flashes, decreased interest in sexual activity, and problems with adding on truncal fat, and problems keeping on muscle mass when they have hormonal therapy. Hormonal therapy is medicine that lowers your body's testosterone production. Within a few days of starting hormonal therapy, your testosterone will be very low to undetectable, and your body can tell the difference. So you have to put up with hot flashes, maybe not as much energy or strength in the weight room, and usually less sex drive. These are things that most gentlemen have to put up with during the course of hormonal therapy. When you take the hormonal therapy for 2 to 3 years as recommended with external beam radiation or a seed implant and external beam radiation, you have to put up with these problems for a longer period of time, and other things can be more problematic to take care of. For example, if you have diabetes or high cholesterol, anemia, or calcium loss from your bones, having low testosterone can make those problems more difficult to manage. So it's very important that you keep up with your primary care physician during the course of hormonal therapy after radiation is over. Because of that, we do consider side effects and toxicities that can be associated with hormonal therapy and radiation therapy. Typically, you do have to put up with bladder irritation, and you have to put up with feeling a little bit more tired than usual. Some patients also have looser bowel movements, even some diarrhea sometimes. However, these symptoms can usually be controlled with diet changes or over-the-counter medications. But if you have problems like this during treatment, it's not unexpected, and we do have ways to manage them. Typically, the side effects from radiation therapy will peak a few weeks after we start and then plateau. They typically don't continue to get worse the whole time during the course of radiation therapy. Usually, after the completion of radiation therapy, the side effects will stabilize and then slowly improve over time. But it may take several months or even a year or so to get back to normal. If you have a seed implant as part of your treatment, the side effects can be more severe than if you don't have a seed implant as part of your treatment regimen. The side effects usually that are more severe are the bladder irritation symptoms, like having to get up more often in the middle of the night or having a weaker stream or some burning when you pee. Usually these things are mild to moderate, but they may be more severe if you have a seed implant as part of your regimen. Side effects from surgery do happen, just like they do with radiation. The difference in these treatment approaches is in the toxicities that may happen and the way people choose between surgery and other treatment options are by the side effect profile that they want to most avoid or that they're most willing to put up with. With surgery, it is a major operation, so you have to stay in the hospital for a day or two. These days, most people are out before 3 days after the surgery is done. You have a catheter in your penis and into your bladder for about a week to 10 days in most cases while you're healing up. When they remove the catheter, there is some leakage that happens sometimes, and most men have some form of incontinence issues right after the catheter is removed, but usually within the first month or two, those leakage issues almost always resolve. Most patients will have very little problems with leakage by the time several months to a year roll by. But there is the possibility that you could have permanent problems with leakage and have to wear a pad or diaper after surgery. The numbers vary from 5 to 10% at most experienced institutions. So you can have to consider that there is a significant risk of incontinence and the need for a pad or a diaper with radical prostatectomy, although most men can avoid that. Now, when they do a radical prostatectomy, they remove the prostate and then they pull the bladder neck down to connect it to the urethra remnant, the two parts of the plumbing that we talked about earlier. When they do that, that affects the bladder shape and the way the bladder works. So there are some bladder irritation symptoms in most patients that I see that have had a radical prostatectomy. Again, these are peaked when the catheter is removed, and they usually resolve within a few months. But there can be some bladder changes with radical prostatectomy as well. With radiation in general, we are using procedures that are less invasive than radical prostatectomy. Because we're not removing any part of the plumbing, the risk of leakage is very low. Usually only 1 or 2% will have to wear a pad or diaper after the procedure. So leakage is not an issue with radiation. Radiation does cause bladder irritation though, so there can be bladder changes. And unlike surgery, there's also a risk of bowel issues with radiotherapy. Radiotherapy can cause irritation of the bowels, causing you to have more frequent or looser bowel movements after or during and after the radiation therapy is complete. So surgery causes more leakage issues, but radiation causes more bowel issues. The bladder changes can occur with both approaches. So those are the biggest differences between the two approaches, radiation therapy or surgery. They can all cause problems with sexual function or erection. Now, most men who have surgery or radiation for prostate cancer, if they have good erectile function or good sexual function before we start treatment, they have a good chance of having excellent erectile function or sexual function afterwards. So the things that influence whether you're able to continue to have normal or good erectile function and sexual function after treatment, the biggest one is the status of your erectile function or sexual function before your therapy starts, and that's true for either surgery or radiation. So they both have risks of causing problems with erectile function or sexual function. I haven't mentioned cryotherapy yet. Cryotherapy is generally used for older gentlemen. It involves freezing the prostate in an outpatient surgical procedure. The reason I mention it's for older gentlemen is that it has a much higher risk of impotence after cryotherapy or problems with erections than either surgery or radiotherapy. So we usually don't consider it for gentlemen that are still sexually active. When we talk about radiation therapy, there are two general ways to think about radiation therapy. One is external beam radiation therapy. External beam radiation therapy is typically done with X-rays, and there are newer centers that use protons. But the idea is that you lay on a table, a big radiation generating machine rotates around your body and delivers X-rays or external beam radiation from various angles. The treatment is usually very quick. It takes 5 or 10 minutes. You don't see or feel anything. You lay on the table, you get your treatment, and then you get up and go on about your business. It's the least invasive approach to treat prostate cancer. The other approach that is a radiation therapy other than external beam is called brachytherapy. And brachytherapy means placing radioactive material in and around the prostate. So there are different ways to do this as well, but the one that we generally use here is called low-dose rate implants or low-dose rate brachytherapy done with small radioactive pellets or seeds. This is done at an outpatient surgical procedure. It does require general anesthesia, but patients go home the same day. So you come in the morning and you're usually on your way home by noon. There's very little downtime. Usually you have some hangover from the anesthesia the following day. On Sunday, if we do it on Friday, on Sunday you're a little bit sore, but back to your normal activities. And most gentlemen that have a procedure on Friday for a seed implant are back to work on Monday. So it is more invasive than the external beam treatment, which is the least invasive approach, but it's a lot less invasive than a radical prostatectomy, which requires part of your plumbing to be removed. So on the scale of invasiveness, prostatectomy is the most invasive, but it's a one-time procedure. A seed implant is the next least invasive, but it does require general anesthesia and an outpatient visit to the hospital. If you have external beam, that is the least invasive approach and requires no anesthesia, and it's all done on an outpatient basis. The other side of that coin, however, is that the least invasive approach, external beam radiotherapy, requires 40 to 44 treatments. So it's a little bit of radiation treatment, 5 or 10 minutes a day, Monday through Friday, but it takes 8 or 9 weeks to deliver the whole course. So there's pluses and minuses to each of these approaches, whether you have a seed implant or you have external beam radiation therapy or you decide on a prostatectomy. If we're talking about radiation therapy or surgery, there can be long-term effects from the treatment. Most patients avoid these, but it is possible whether you have surgery or radiation that you could have some problem that shows up months or even years after your treatment is over. The most common one, as I mentioned, with surgery is leakage or incontinence. You can also have problems with erections, as we mentioned, and radiation therapy likewise can have problems that show up later. The incontinence issue is a low risk with radiation, whether you have a seed implant or external beam. But if you have radiation therapy, you could have some other things that show up as the months or years go by. The most common thing that we see is bleeding in your urine or in your bowels. This typically happens, if it's going to happen, about 6 to 18 months after your radiation is over. It only happens about 20 to 25% of the time, so 1 in 5 or 1 in 4 patients will come back and tell me in a follow-up visit, "Doc, I saw some blood in my urine or blood in my stool, what do we do?" When that happens, usually it'll go away on its own, especially if you can avoid constipation. But if it continues to persist, then we need to check it out and make sure we're not missing something like a polyp or some other problem that it's bleeding. If it's bleeding from the radiation, which can happen, we can do a no-touch procedure during the colonoscopy or during the scope that can make the bleeding stop, and usually that's all we have to do. As I mentioned earlier, any treatment for prostate cancer, including radiation therapy, can cause problems with sexual function or changes in sexual function and problems with erections. However, there are a lot of good medicines these days and other things that we can use to improve that problem. So even though we may cause you to have more trouble with sexual function, we have a lot of good ways to make that better. So radiation, like surgery, can cause problems in that area. Finally, there are a couple of things that are very rare but could be very significant if they were to happen to you. The risk of something very bad happening with the treatment for prostate cancer is not zero, whether you have surgery or whether you have radiation therapy. If you have either one, it's possible that you could have an outcome that we would like to avoid, that would require surgery to fix, or transfusion for severe bleeding, or some other problem like that. The good news is that the risk of something this bad happening is very low. It's approximately less than 1% that anything that severe would happen if you decide to have your prostate cancer treated with radiation therapy. One of the differences between intermediate risk and high-risk prostate cancers is the duration of hormonal therapy that is needed to treat the cancer if you're selecting radiation therapy as your treatment modality. So if you don't have surgery and you go with radiation, hormonal therapy has been shown to improve outcomes in patients with high-risk prostate cancer. It does come at a price. There are side effects from taking hormonal therapy for 2 to 3 years. Most patients have hot flashes, decreased interest in sexual activity, and problems with adding on truncal fat, and problems keeping on muscle mass when they have hormonal therapy. Hormonal therapy is medicine that lowers your body's testosterone production. Within a few days of starting hormonal therapy, your testosterone will be very low to undetectable, and your body can tell the difference. So you have to put up with hot flashes, maybe not as much energy or strength in the weight room, and usually less sex drive. These are things that most gentlemen have to put up with during the course of hormonal therapy. When you take the hormonal therapy for 2 to 3 years as recommended with external beam radiation or a seed implant and external beam radiation, you have to put up with these problems for a longer period of time, and other things can be more problematic to take care of. For example, if you have diabetes or high cholesterol, anemia, or calcium loss from your bones, having low testosterone can make those problems more difficult to manage. So it's very important that you keep up with your primary care physician during the course of hormonal therapy after radiation is over. So the goal of treating your prostate cancer, even with high-risk disease, is a cure. Even gentlemen with high-risk prostate cancer can expect not to die of prostate cancer. Most gentlemen with high-risk disease do not die of prostate cancer. The studies that have been done combining hormonal therapy with radiation have shown that we can expect to cure at least 50% of gentlemen with high-risk disease, and maybe more with modern techniques and newer drugs. So we're looking forward to treating your cancer and you living many more years. You do have choices, and you should discuss them with the radiation oncologist and your urologist. I also feel it's very important that patients understand that clinical trials are a great opportunity for them and for society. We want to learn how to better take care of cancer, and in this case, prostate cancer. MUSC and Hollings Cancer Center is an NCI designated center, and what that means is our prime goal is to take care of patients the best way possible and to learn how to improve cancer outcomes. I'll urge you to ask about clinical trials regardless of where you decide to get your prostate cancer treated.